All right, future nurses, welcome. If you've got that big final exam breathing down your neck, you are in the perfect spot. This is your high-speed final cram session on the 10 topics you absolutely positively have to know. Ready? Let's jump right in. So here's the mission. We're going to fly through 10 of the heaviest hitting concepts that show up on exams, and we're going to do it fast. But look, this isn't just about cramming facts. It's about building that confidence so you can walk into that testing center feeling like you own the place. Let's do this. So here's our game plan. We're breaking this down into a few key areas. We're going to start with lungs and gas exchange. Then we'll do a deep dive into all things cardiac. After that, it's a rapid-fire round on blood, fluids, and pressure. And then we'll pull it all together to make sure you're truly ready. First up, let's talk about the lungs. We're going to tackle two topics that can really trip people up, but trust me, once you know the secret, they're not so scary. We're talking about arterial blood gases and ARDS. Okay, whenever you see an arterial blood gas problem on an exam, I want you to take a deep breath and just think of one word, ROME. It's the only mnemonic you need. It stands for respiratory opposite, metabolic equal. So if the pH and the PaCO2 are moving in opposite directions, like one's up and the other's down, it's a respiratory issue. If the pH and the bicarb, the HCO3, are moving in the same or equal direction, both up or both down, it's metabolic. This little trick is your key to unlocking every single one of these problems. All right, let's put it to the test right now. You get this question. A patient's pH is 7.25. Well, that's low, right? So we're in acidosis. Their PaCO2 is 55. That's high. So, are the pH and PaCO2 moving in opposite directions? Yes. One is down, one is up. That is respiratory opposite. It's respiratory acidosis. And since the bicarb is totally normal, it's uncompensated. See? Simple. You got this.
Next up, ARDS. Basically, this is when the lungs get super inflamed and start filling up with fluid. Now, for your exam, there is one thing that is absolutely critical to know. It's the PaO2/FiO2 ratio, also called the PF ratio. This number tells you exactly how bad the damage is, and the magic number you have to burn into your brain is 300. If that ratio is less than 300, you're dealing with ARDS.
So let's try it out. Your patient has a PaO2 of 80, and they're on 100% FiO2. The only trick here is you have to turn that FiO2 percentage into a decimal, so 100% becomes 1.0. So what's 80 divided by 1.0? It's 80. And is 80 less than 300? Oh yeah, this patient has severe ARDS. The math is really that easy. Okay, moving on from the lungs, let's head straight to the heart for our cardiac deep dive. We're going to hit heart failure, MIs, and we're going to look at a rhythm strip that you are pretty much guaranteed to see on your exam. Let's make heart failure super simple. All you have to remember is this. L is for left, and L is for lungs. When the left side of the heart fails, fluid backs up into the lungs. That's where you get your crackles, your difficulty breathing, that classic pink frothy sputum. And for the other side, R is for right, and R is for the rest of the body. When the right side fails, fluid backs up everywhere else. That's what gives you the swollen legs, the jugular vein distension, or JVD, and a swollen belly from ascites. So, pop quiz. Your patient has JVD and big swollen legs with +3 pitting edema. Now ask yourself, are those symptoms in the lungs or in the rest of the body? That's the rest of the body, right? So R is for rest of body, which means you're looking at a classic case of right-sided heart failure. When someone's having a heart attack, an MI, the damage happens in stages. First, you have ischemia. The tissue is screaming for oxygen, but it's still alive. We can save it. Then you get to the zone of injury. Now there's actual damage, but we might still be able to salvage some of it. The final stage is infarction. That's dead tissue. It's irreversible. Game over for those cells. So that's why an ST elevation on an EKG is such a big deal. It points to that zone of injury, which is our last chance to intervene before it becomes permanent. You are definitely going to see rhythm strips on your test. So what about this description? An irregular rhythm with no discernible P waves. What does that mean? It means the atria are just kind of quivering instead of beating properly. It's chaotic. This is the textbook definition of atrial fibrillation, or AFib. Irregularly irregular with no P waves, that is the phrase you need to know. All right, let's switch gears. It is time for our rapid fire round. We're going to nail down 5 topics that are all connected: labs, fluids, shock, and brain pressure. These things show up all over the place, so let's lock them in.
2 lab tips that will save you a ton of points. First, the left shift. If you see a lab report with a high white blood cell count, high neutrophils, and high bands, and remember, bands are just baby neutrophils, That means the body is in full-blown panic mode, cranking out an army to fight a nasty bacterial infection. Second, hematocrit. If the hematocrit looks weirdly high or low, the very next lab you should look at is the sodium. It tells you if the blood is too watery or too concentrated. So if you see a high hematocrit and a high sodium, what are you thinking? Dehydration for sure. That's hemoconcentration.
Okay, quick check on that. Your patient's labs come back. White blood cell count is 28,000, and they've got high neutrophils and high bands. What should be screaming in your head? That's a left shift. It's pointing straight to a severe bacterial infection, and you should be thinking sepsis. Okay, let's talk about third spacing. This happens when you dump a bunch of IV fluid into a patient, but instead of staying in the blood vessels where you want it, it leaks out into the tissues. So you get this weird situation where the patient is puffy and swollen, but their blood pressure is still in the tank. If you see a patient who's getting tons of fluid, they're gaining weight, but they're not peeing and their BP is still low, you're looking at classic third spacing. Now for shock. You'll often see questions that make you choose between different types. Here's the number one trick. Almost every kind of shock involves low blood pressure and a fast racing heart rate. The body's trying to compensate. But there is one huge exception, neurogenic shock. Because the nervous system itself is damaged, you get low blood pressure and a low heart rate, bradycardia with hypotension. That's the golden ticket for identifying neurogenic shock. So let's apply that. A trauma patient from a car crash comes in, their blood pressure is 80/50, and their heart rate is only 45. What's jumping out at you? You've got both hypotension and bradycardia. That specific combination should make you immediately suspect neurogenic shock, probably from a spinal cord injury. Last one for this round, and it's a big one, cerebral perfusion pressure, or CPP. This is literally the pressure that's pushing blood into the brain. You absolutely have to memorize this formula. It's not optional. CPP equals MAP minus ICP. That's your mean arterial pressure minus your intracranial pressure. So if your patient's MAP is 90 and their ICP is 15, what's their CPP? You just do the subtraction. 90 minus 15 is 75. You have got to know that formula cold. And just like that, we've blasted through 10 of the most important topics you're going to face. So, after all that, the big question is, are you ready? Look, you have put in the hours. You know this stuff. You have all the individual puzzle pieces. The final step is just trusting that you know how to put them together. Trust your knowledge and trust your gut. You know how to think critically. So let me leave you with one final question to pull it all together. Think about this. How can a heart attack lead to cardiogenic shock? And then, how can the fluids we give for that shock cause third spacing, which then floods the lungs and makes a patient's ARDS even worse? That right there, that's nursing. It's about seeing that chain reaction before it happens. You see how it all connects? The heart, the lungs, the fluids, the pressure. It's all one big system. Keep practicing connecting those dots and you are going to be just fine. Now go get 'em. Go ace that exam. You've got this.